So the purpose of this webinar today, we've got 90 minutes today. If you need to dip out, that's okay. We are going to record, so this can be onto the website afterwards. So the purpose is fairly clear from the title slide. It's on economic evaluation in social care, and I do want to emphasize that it is an introduction. So there are some techie issues that we won't get into in the presentation. We can address some of them in the discussion later on in the Q&A, or we can certainly pick things up offline with you. As I said earlier, this is part of the SSCR Webinar Series in capacity building, and there is an SSCR study called Essence that Annette, Michela, Helen, myself and others are working on, and we'll have a slide on that later on. And Essence is not doing economic evaluation in social care, it's trying to pull the information together. And just to say, we'd be very keen to work with you. And I just want to say at the beginning, remember a colleague of ours, Aya Kettunen, who unfortunately very tragically died last year, who was working with us in this area. So I just want to remember her as we start off this webinar. So let's then go, and that picture, by the way, is taken about 300 meters from where I'm sitting on one of those sunny days we used to have in England. Okay, so the structure. First, we're going to say something about why we need economic evaluation. Should be fairly obvious, I think, but we'll just quickly say something about that. Then talk about research design. It's not a webinar on research design itself, but we do need to say something about how studies are conducted, because that does have an impact on how the economic evaluation gets done. And then there are three main components to an economic evaluation. I tend to think, well, design is one of them, I guess, but measurement of cost, measurement of outcomes, and then how you bring the two together, the costs and outcomes in some sort of trade-off. So we'll go through those. I will go through those in terms of the principles. Please remember, again, it's introduction to what we're doing. Then we'll give some examples, and each one of us will give an example. And then very, very brief at the end, some challenges, and then we should have plenty of time for Q&A. So hopefully that's what you signed up for with this webinar. So why do we need an economic evaluation? So the underlying problem, just to state the blindingly obvious, is scarcity. We don't have enough resources. That's either us as individuals, or us as providers of services, or us as commissioners, or us as a government, whatever. We don't have enough resources. And so we need to choose how we're going to use those available resources. And in choosing, we'll have various criteria that we will use to guide our choice. It may be that one of those criteria is how to get the very best out of our resources to be the most effective we can with the budgets we've got, for example. So the underlying problem is choice, and is scarcity rather, which leads to a need for choice, and then that leads into the way that economics can help. And so at the bottom there, I put consequently any new policy idea or intervention. I'm going to use the word intervention a lot in this talk, and that could be a service, it could be a treatment in the healthcare context, it could be a preventive strategy, whatever. But this intervention will be looked at very carefully, and the questions will be: is it effective? Is it affordable? Does it save money? And is it cost effective? And those four things are different, and we'll explain what they mean a bit later on. And then to emphasize importantly throughout this, that economic criteria, I would say economic criteria are absolutely essential, but they are not to be dominant. They should not dominate other criteria. They should be seen alongside other criteria for making decisions about how to allocate. And fairness is a very obvious one, another criterion. So where then can economics be helpful? So I'm going to just, on this slide, I've just got some areas where economic information is being used in the social care and closely related areas. But the focus that we have in this webinar is on economic evaluation, and some of the things listed here are not that part of economics, if you like. So there's a bunch of things at the beginning. where economic evidence or economic data is used to compare between services, between policies, and so on. So how does the cost of daycare vary from one locality to another? How does spending vary? Those are all economic things. Economics can help in guiding commissioning. Certainly economic evaluation can do that. And that could be commissioning or decision making by individuals themselves to find out what works and whether they can afford it. Then there's the things where providers of services or people who are marketing products, might be assistive devices, might be medications and so on. Those providers are selling things. Economic information can sometimes help them in doing that. Then there's a whole set of strategic decision-making processes, managing a system. So governments looking to manage the care system or the health system or other systems we'll come back to. Guideline development, and we'll see something about that later on. NICE, National Institute for Health and Care Excellence, develops guidelines in the social care field now, as well as the health and public health fields. And so they make quite substantial use of economic evaluation. And it may be that economic evidence could be used for regulation or inspection of services. That will vary quite a lot. And then finally, sort of very, very strategically, for broad policy development and for broad policy lobbying, if you can use that term, economic information is used. So lobbying groups, particular areas like dementia or autism or learning disability, might use economic evidence to try and show the importance of their area. And at the bottom there, I put the different uses, uses of economic information will require different types of data to some extent and different analyses. So what we're going to show you here is a sort of general approach to economic evaluation in social care. And some of that will be relevant to many of those different areas on the slide. And one thing to say at the beginning, in case I forget to say it later on, economic evaluation of the kind we're talking about here is much more developed in the healthcare field than in the social care field. And so social care economic evaluation has often borrowed a lot of things from the healthcare field, and some of the language we use is in the healthcare field. So we'll try and make that clear as we go through. Okay, so what is the core economic evaluation question? And it sort of follows on from the two questions, or the first question there is, if the policy question or the practice question is this intervention effective? Is this service effective? Is this preventive strategy effective? By reference to things I'll come back to in a moment, then the economic question is saying, is it worth it? Okay, is it worth spending money on that intervention, given what we know about its effectiveness? So the economic question must be seen in the context of that effectiveness question. And as I always say with this thing, the economic question is 4 words. Is it worth it? And the answer to the economic question is 2 words. And they're not rude. I'm going to come back to that later on. Okay, so the answer is 2 words, and I'll explain what those 2 words are in a moment. So what we have to do then is to think about, what do we mean by effective? What do we mean by worth it? And that then takes us to the measurement of outcomes and costs, which we're going to come on to in a moment. And then it takes us later on to the trade-off question. The decision maker might have to face a difficult choice. It may be that to achieve greater effectiveness, the decision maker has to spend more money. And so there's a trade-off that needs to be, there's a misspelling as well, better in there, but a trade-off has to be balanced up, if you like. So these then are the building blocks for economic evaluation, and one can be much more nuanced and finely grained than this, but these are basically what we're talking about. We're talking about the design of a study, and I'm going to show you, I think, one slide on that. The measurement of costs, the measurement of outcomes, bringing them together, and then making some recommendations. So as we go through, we're going to just talk about those 5 briefly, and then the illustrations of the 4 studies we're going to talk about. Those will illustrate how those different building blocks have been operationalized. And before I get to the design thing, just one quick word about language. There are many different words you will see used when talking about economic evaluation, and this is just some of them on the slide here. I'm not going to read them all out, but different terms will be used. They don't mean exactly the same thing, but as I put on here, we will define these terms later, though this is not a webinar in language analysis, but the terms are not used consistently, unfortunately, and so it is sometimes difficult to know what is being described by a particular type of evaluation. I think health economists are pretty consistent, but economists more generally, different parts of economics have used different language, so you just need to be clear what is behind the term that's being used. Okay, so on to the design question. And these are the main approaches. I'm going to show you, I think, one more slide after this one in this section, very little in this section, because we don't need to go into details of design. And in the SSCR Webinar Series, we've already had some good webinars on different approaches to research and different designs. But basically, in economic evaluation, you'll see these are the most common designs you will see. They are not designs that are peculiar to economics. They're designs that apply across all different areas of evaluation in the social care or healthcare or other fields. So the first one is a simple before-after calculation or comparison. What do people look like at the beginning? What do people look like after they've had the service or the support? What are the outcome calculations, if you like, and what is the cost difference between before and after? It's a very simple, very crude, quite limited study. Doesn't mean it's useless, and not at all useless, but nevertheless, it's quite limited in what it can really tell us because we haven't compared with what would have happened in the absence of that intervention. So that's one. Then the other four on the slide here all have what I've called a parallel comparison group. So as well as looking at the people who are getting the intervention that you're evaluating, there are also some other people who are getting either a different intervention or getting nothing or getting standard care and support. And you can allocate people between the intervention group and the other group, the comparison group or control group, in a number of ways. And the first way is to randomize, and the examples we're going to show you later on, two of them, randomized trials. They're not that common in social care even today, but they are quite powerful designs for certain purposes. They're not, some people call them the gold standard. I don't like that term myself, but they are quite powerful in some ways. Secondly, we've got a quasi-experimental design where you allocate people to interventions, if you like. The researcher is doing that, but it's not done in a random way. Thirdly, we've got observational studies. These are very common in social care. We just look and see where people are within the system, what sort of services they're getting, and make comparisons between them on their effectiveness and their costs. And then fourthly, we've got something called mathematical modeling. And I'm going to show you a little picture of one, and then one of the examples later on that Annette is going to talk about will be an example of a mathematical modeling study in the social care area. So this slide is not on social care. You can read at the very top. It's about contraceptive advice. Why have I put that in there? Well, because it's an example that is here in this methods review by Squires and Tappenden, which is in the SSCR series from quite a few years ago now. It's a really nice introduction to mathematical modeling or modeling approaches in evaluating in the social care area. And they just have this example. So I've copied the slide from there. So what the modeling is doing is saying we don't observe what happens to people, we just simulate what we think would happen to people, in this case whether they got a contraceptive device or didn't, and then if they did get the contraceptive device, would they use it or not use it? If they did use it, would they get pregnant or not get pregnant? And you can compare, you can simulate what happens. So this kind of modeling, I'm not going to go into detail, and Annette won't go into great detail when she gets to the example, but it is a simulation approach, and it allows you to do some evaluation, even if you haven't got time or money to go out and collect lots of new primary data and follow people for long enough to see what really happens. So you can measure intervention costs, you can measure costs and outcomes at the end, but you take data from other places. And this is quite commonly used in economics. It's not the only, it's by no means the only economic evaluation method that's used, but it is something that economists find helpful to use when you can't do other forms of evaluation. Okay, so let me go on then to the quickly through the two main sections in terms of measurement. One is on costs and one is on effectiveness or outcomes. And in the cost side, there are three areas I want to just talk about: the breadth of measurement, the utilization measures, and the unit costs. So the first task then is to decide which costs are relevant. Which costs do we need to measure? I'm going to talk about that in a moment. Secondly, then once we've decided what we need to measure, how do we measure? And we go away and do the measuring. And then thirdly, we attach costs to those things that we measure. So if we're measuring how many times somebody goes to a day center, then we need to know what is the cost of attending a day center. So those are the three elements. So this first one then, what is the breadth of cost measurement? We need to decide in the study how broadly we want to measure costs. I'll show you an example, a couple of examples in a moment. And economists sometimes call that the perspective. It doesn't matter about the jargon if you don't want to take that on board, but what is the perspective for the study? And it's common for a study to look, for some studies to look at the health and social care system perspective, the sorts of things that are listed there, things that are delivered in the health sector, delivered in the social care sector, what are the costs associated with those? And when NICE does its evaluations, it only looks at this perspective, or tends to focus predominantly on this perspective. But there are other things that are relevant too. There might be other bits of the public sector. So people who use social care might also use other public services like criminal justice or education or housing or so on. And they might get welfare benefits. And then from the societal perspective, not just what's happening in the health and social care sector or the public sector, but the whole of society, there are a whole range of other things. Individuals who use services might pay for services themselves. There might be some loss in productivity from perhaps the carer's perspective because they're having to provide support and so on. So the breadth of the cost measurement is important. In most studies that get done in social care today, researchers would try to measure everything they can, but then for some analyses, they might narrow down the measurement for certain purposes. So usually we try and measure everything, and then you've got lots of choice as to how you want to, how broadly you want to measure. So that's the first thing. Two quick illustrations. One would be, this is a study that we did at LSE a while ago on the costs of dementia, or part of a bigger study. And what you can see here for people are different. I won't go into great detail, but as you go from left to right, we're looking at increasing severity of dementia, and the height of the column is the total cost. And these are different settings for people. The first four are community. The one on the right-hand side is care home. The point about this is there are high costs for different sectors. So the black is primary healthcare, the red is secondary healthcare, the yellowish brown is social care, and the blue is an estimate of the cost of unpaid care. And you can see in relation to dementia, for example, that unpaid care, when you get to more severe forms of levels of dementia, unpaid care is really important. So we need to remember, if we're only going to measure health and social care system costs, we might be missing those unpaid care elements. Okay, that's one example. A second example, quickly, this is now looking at autistic adults, who also have intellectual disabilities, a study that some of us did in Scotland a few years ago. And now you can see slightly different colouring and different column definitions. These are age groups 0 to 1, 2 to 4, and so on, going from left to right. And you can see different costs coming in now. Costs of special accommodation, basically, costs of special education, health and social care, productivity losses for the person with autism, productivity losses for parents, and benefit payments. So again, a broad range of costs that could be quite important when we're thinking about doing an evaluation in a social care topic area. So that was the first element, that what cost do we need to measure? The second one is how do we measure them? This is what we often call utilization patterns. And there are many ways to do this. Some of them are not immediately available. So, at the bottom there, I put management information systems or billing systems, which are sometimes used in some countries. Well, if you haven't got very good data, particularly not accessible data, then you can't use the electronic case files or whatever else. So quite often what you see in studies are these methods used up here, where you ask the person themselves, the person with social care needs, what services have they used in the past month or 6 months or whatever it may be. Or you ask a proxy, which might be a family member or a care staff member or somebody else like that. So you're asking them to tell you what services they've used. Now, there might be lots of worries about how accurate that would be, and I would share those worries in many cases, but it's often the only method we've got to collect that information. It's not as inaccurate as sometimes people think when you compare it with when you have got case files. It doesn't, that recall method doesn't work too badly. Some people use diaries that people complete every day to say what services they've used. That can be more accurate, but people sometimes get a bit fed up with filling that in, and so you don't get complete data. And you could go to case files and so on. So basically what you're trying to do is to find out how often somebody went to a day centre, or did they have an inpatient hospital admission? Did they go into a care home, and so on? As I put in the box at the bottom there, and this is something to come back to the very end, these data are very easily and cheaply collected alongside outcome evidence. Economic evaluation is not difficult and expensive to do if it's part of a wider evaluation. And then the third element is unit costs. For each of those services, you want to attach a unit cost to say, okay, this is the cost of delivering that particular day centre hour or whatever else. There are different ways of doing that. I'm not going to go through the great details, but I would say to you that in the middle here, I've said this previously calculated method. PSSRU at Kent have more than 20 years been producing an annual volume of health and social care costs. I put priceless, partly because it's free to read online, but it is priceless in the sense it is so valuable, and it just saves an enormous amount of time in calculating those costs. Okay, I'm going to keep zipping through in the interest of time. Just one thing to say before I go on to outcome measurement is about the cost of unpaid care. This is so important in social care. So how do we measure it? You want to find out whether carers are paying for things out of pocket, for travel or so on. There might be some lost earnings if somebody is wanting to be in employment but is having to give up some or all of their employment to be a carer. That will impose costs. There might be some benefit payments to look at. There might be some impacts on the carer's own health. So you could look at the cost of the health services that they use because of the stresses of being a carer. And then importantly at the bottom here, what about time that they spend in being a carer? And you can attach a monetary value to that. And we're not going to go into any detail about those, but the studies in the social care area now would normally include some estimate of that cost of unpaid care time. As you can see, we're skipping over loads and loads of details of things that you can follow up later with us if you want to. Okay, let's go on to the outcome measurement side. And there are 4 approaches, and I'm going to say something very quickly about the 4 of those. So this, first of all, is a busy slide, and I'm not going to go and read through every bit on it, but it sets out what would ideally be the outcome measurement approach we would take. So why would we want to, or how we want to measure ideally? We want outcomes to link to the service aims. So if the aim is to make people independent, then let's measure independence, for example. We want to involve people with lived experience in helping us to decide what to measure and how to measure it. We want to capture the impacts on everyone affected, not just the person with the social care needs, but perhaps their family members, their carers and others. We need to work out how we're going to get the data. So who do we ask? We want it to be quantitative. This is important, but we probably want to support it with qualitative evidence if we can. We're going to assess change over time. We're going to assess ideally change in one intervention compared to another. We might compare with other studies as well, and we're going to take account of time preference. Now, I'm going to skip explanation of time preference because it can take a long time. But if you don't understand it, then you give me £20 today and I'll give you £20 next year. And that's how it works. Okay, so I'll explain that later on in the Q&A if somebody really does want to give me £20. So how do we measure outcomes? This is my ability with computer art, which is not very good. Let's imagine somebody has got that level of well-being. This is a measure of well-being up here and time on the vertical axis, on the horizontal axis. Over time, somebody's well-being gets worse if we don't give them an intervention. So that's what happens without them having an intervention. If we give them an intervention, it may be their well-being improves. They still die at the same age. But over that course of that life, you can see there's been an improvement in well-being. And that triangle, that difference between the two lines, that's what we're trying to measure with an outcome. That's what the outcome is trying to measure. Okay, it's a difference between what happened without the intervention and what happens with the intervention. And then second example very quickly would be if the intervention actually prolongs somebody's life, then the intervention, the outcome measure is that, again, that area between the two lines. So that's the principle of measuring outcomes. We're trying to look at the difference between two interventions at every point in time. Over time, we're trying to measure that difference. We can't measure people continuously, of course, but that's the principle. So then how do we, what are we trying to measure? And there are four approaches, as I've mentioned earlier. So we can measure in terms of what often gets called natural units. We can measure in terms of money, measure in terms of utility, which I'll explain, and then in well-being. So in terms of, skip that, in terms of natural measures, these are the sorts of things that you would be familiar. If you've never done economic evaluation, but you've worked in the social care field, these are the sorts of things you would expect to see in measuring the effectiveness of an intervention. Some of these are health related, some are social care related. So the extent of disability, the degree to which needs are met, and some of these other things are needs. Social functioning, independence, ability to look after oneself, and so on. A whole range of things that you might think will be relevant to measure in this area. And then there might be more process things such as choice and control. How much choice does somebody have over their life? That might be an important outcome. Look at the impact on families and carers and so on. And then there are some generic measures, and I'll come back to those in a bit more detail, which initially started in the health field, but now being explored in the social care field. And one of those is this thing called QALYs, which I'm going to define in a moment. Okay, so one approach to measuring these outcomes is in terms of these sort of natural units. And you will all, I'm sure, be familiar with the Ascot scale. It's not the only show in town, but it is a pretty good show. So it is a measure which is specifically trying to measure, specifically trying to cover the main domains of outcome relevant to adults who use social care services. And there are a whole range of different measures linked to Ascot now. Secondly, then you might want to measure outcomes in terms of money. And I'm going to say very, very little about this, mainly because it's very, very difficult. And what you're trying to do is you're not trying to just measure whether expenditure is saved, which is relevant. Of course, it's relevant, but that isn't what outcomes are about. Outcomes are about achieving independence or self-care abilities or well-being, and attaching a monetary value to those is quite tricky. We've done it in some cases in some proxy ways, but it is quite tricky. But that's what you're trying to do, okay? And on the slide there are some ways in which people have attempted to do that. Almost never I can think of in social care contexts, not very often in healthcare, but sometimes in other areas of economics. So that's the second one. The third one is the area of utility, and this is linked to the philosophy of utilitarianism associated with Jeremy Bentham, who still sits stuffed. You know, he's had all his innards taken out and his skin is stuffed and sits in that glass cabinet in UCL. I don't know why they do that, but there he is. and John Stuart Mill, and then William Stanley Jevons, who is an economist, all associated with this utility approach to. So what we're trying to do, the utilitarianism, is to improve the utility, the well-being, the hedonic satisfaction, if you like, of individuals. That's the ultimate aim, it's thought to be, of society. And this has been translated by particularly health economists into a measure which is trying to be a generic indicator of well-being, or of, in this case, health-related well-being. So outcomes measured in terms of utility, then, what you will see people look at is something called a quality adjusted life year, which says how long does somebody live for, how many extra years perhaps do they get because of the intervention, and what is the quality of each of those extra years. And quality is just, the quality is arbitrarily set at 0 is the worst and 1 is the perfect health that you might have. And so many evaluations in the health field would then look at, as well as symptoms and clinical outcomes of various kinds, would also include this generic health-related quality of life measure called a QALY. And the most frequently used tool for measuring it is the EQ5D. So I put on here some examples. I'm not going to go into details, but if you look at any, I would say almost every single, not every single, 95% of economic evaluations in the health field in this country would use an EQ5D based utility measure. And economists at York have been particularly leading the way in this tool. And then there are some condition-specific ones. I can think of two. One that might be relevant. One is for dementia, one is for mental health. And then the Ascot tool, which I've mentioned before, that's been turned into a social care QALY. So you can use this generic measure, not usually to replace the natural measures, but to supplement them. And then finally, there are outcomes measured in terms of well-being. This is in the most general sense of well-being, and I'm going to show you a slide from the What Works Center for Well-being, which I think illustrates the different ways in which we can measure it. It could be in terms of functioning, which is sort of natural units we've been talking about before. It could be in terms of environment and external conditions. We sometimes think of well-being in that sense, our productivity, our income level, and so on. And then it could be things in terms of our feelings, our good feelings, a hedonic hedonism, as the Greeks would say, our good feelings of living in the moment, how good we feel in that overarching subjective sense. And that is also very relevant in a social care context. Okay, so those are the ways to measure outcomes. Let me then move quickly to trade-offs, and then we can get to some examples. So the trade-offs thing, I'm going to show, this is a slide I showed you before. What we're trying to do now is to bring together the outcomes and the costs. And I can now, in a minute, tell you my two-word answer to that question, the is it worth it question. Okay, so this is a simple situation. Let's say you do an economic evaluation or doing an evaluation, and you find that one intervention, one service, whatever, is more effective than the other one. And it's also going to save you money. It's less costly. And then economists, health economists, would call that a state of dominance. They say that the first intervention dominates because it's better in terms of outcomes and it's cheaper in terms of costs. So what's not to like? It's great. Okay. Why would you not want to recommend that to the decision maker? The decision maker may not take it up. They may think that other things are more important than that result. But nevertheless, this is an easy economic evaluation. But the fun comes when you've got the opposite situation. And the example here would be an intervention is more effective than its comparator, but it's also more costly. And so the decision maker or somebody has to decide whether it's worth spending that additional cost to achieve those better outcomes. And that is it worth it question, as I say, is core to economic evaluation. And this is the only bit of algebra you're going to get, I think, today, unless one of my colleagues is going to give you something horrible later on. But I think this is just summarizing what the economic evaluation is trying to do. And health economists use this thing called an ICER, an incremental cost effectiveness ratio. And it's very simple. It's the difference in costs. C is cost, E is effectiveness or outcomes. It's the difference in costs between two interventions. Two is perhaps the new one is the standard one. That difference in cost divided by the difference in an outcome measure. It might be a QALY, it might be your primary outcome, such as ADL score or something else. But you're just summarizing the difference in cost between the two things you're evaluating and dividing by the difference in their effectiveness. And that's the basic tool for then deciding and recommending, or deciding whether something is cost effective and whether or not to recommend it for action. So then what health economists would often do is go to this quadrant diagram. And I'm going to just illustrate this because this is important for understanding the challenge. So on this diagram, the vertical axis shows you the difference in costs. The horizontal axis is the difference in outcomes or effectiveness. Okay, and I can just locate, I can plot on that diagram the result from my evaluation. So if my evaluation puts me down here, it says that service 2 is more effective and also less costly than service 1. And that's kind of bingo, okay? Why would we not want to go with it? Service 2 is better and it's cheaper. So that's a nice, easy easy conclusion. Up here, it's also an easy conclusion. Service 2, our new service, is less effective than what we do at the moment, and it's going to cost us more money. Nobody's going to be interested in that, okay? They shouldn't be, not from an economics point of view. But the challenge then comes in this quadrant and the other one, where at the first one, service 2 is more effective, but it's also more costly. And in the bottom left, the new service is less effective, but it's going to save us money. So the question would be, let me just go back, those quadrants I'm showing you at the moment, the cost effectiveness finding is very easy. We recommend in the bottom right-hand corner, we recommend service 2, top left-hand corner, we recommend service 1. Challenge comes with the other two. And so the question would be, is it worth it? And the answer, my two-word answer to that question is, it depends. Okay, it depends is the answer to economic evaluation. And I can illustrate that here. So let me show you these 2 points, A and B. Now, if A is the result of our evaluation, what that tells me is where I've located it, it's going to save us a shed load of money. It's going to save lots and lots of money compared with what we're doing at the moment. But the outcome, because I'm left of this vertical line, the effectiveness or the outcome is slightly worse. So is it worth doing? Well, the decision maker is going to save loads and loads of money, but people are going to have worse outcomes. Is it worth it? The economist doesn't know, and the economist can't decide. It's not for the economist to decide. Over here with B, what we're saying is the cost, the cost saving is very small, but there is a cost saving that's quite attractive. But the effectiveness is way, way worse than we have at the moment. So is that cost effective? We don't know. It depends again on how the decision maker trades off the outcomes and the costs. Now, I'm pretty sure that A looks more attractive than B, but I still can't tell you that A is cost effective, okay? Because it depends on how much we want to attach a value, if you like, to the worse outcomes. And if we go to the top right-hand corner, I'm not going to belabor this, but again, you've got two situations where Z is saying, actually, this is much more expensive than we have at the moment, and it's only slightly more effective. It doesn't look quite so attractive as Y, where we've got much better effectiveness for people using the services, the new service, and it's only slightly more expensive. So I'm sure Y looks better than Z, but I still can't tell you whether it's cost effective because it depends on that trade-off. Okay, so this is key. Health economics, social care economics, economic evaluation is 90% science and 10% value judgment. And so at the end of the day, somebody has to decide whether that is worth it. So how is that done? I'm not going to go into detail because I want to move on to the examples, but you can show the decision maker that evidence and leave them to choose. And decision makers are paid lots of money, so why not give them lots of responsibility to make those decisions? That's what they do. That's what they're skilled in doing. What you can also do, and this is the third bullet point here, is what NICE does. And NICE, on behalf of the health and now the social care sector as well, has got this very, very rigorous. I think NICE is a very, very impressive body and does very, very impressive work. What they've got is a sort of threshold to guide decisions. And they would argue that if something in the healthcare sector costs more than £20,000 for each additional QALY, each additional quality adjusted life year, if it costs more than that, they're not so likely to recommend it for use within the health service. If it costs less than that, they are likely to recommend it. Now, the threshold is not the only thing that guides them. There are other things, and Annette is going to give a very nice example of that later on. But what NICE are trying to do is to help society, so on behalf of society, help us to decide, is it worth it, by setting this standard that people can then use to compare all different healthcare and now social care interventions. Okay, now on this slide, I'm not going to go through this slide at all. I've listed the different types of economic evaluation. It's not necessary for us to go forward in the webinar. You can look at this in the recording or the slides later on. It's just to explain there are different ways in which you combine costs and combine outcomes to do these evaluations. Okay, so we're going to go into some examples. I'm going to skip my example, which is the carer support one, in the interest of time. Happy to the slides to be on the pack you can see later on the website. So I'm going to go to example B, and Annette is going to take us through that. So if I just skip on to the slides. Which is there. So Annette, I'm going to hand over to you, and hopefully when you're speaking, these pictures will still stay on the screen. Just tell me when you want me to move things. So Annette, over to you.
Thank you. Yeah, maybe I just start by saying, so I mean, as Martin, I think, mentioned, NICE has produced not just clinical and public health guidelines, but since 2012, it also produced social care guidelines. And that was done from 2012 to 2018, I think, by the National Collaborating Center for Social Care, so short NCCSC. And that was actually a partnership led by SCI, Social Care Institute for Excellence, and partners included Epicenter for systematic reviews, and the economic work was done by our center, and the impact work was done by Research and Practice. And so for our center, I was the main economist working on those guidelines. I worked on altogether 6 guidelines, and you can see just really the overview of those guidelines that have been produced by the collaborating center during that 6 years. And you can see that kind of like different topic areas. So some of them are more about services and service models. So like intermediate care, which includes variablement, is one example. Some others are more about populations. So there's older people with learning disabilities, which I'm going to talk about a bit more. There are topics on transition, and then there are topics on legal aspects, which includes, for example, decision-making and mental capacity. And then there's also a guideline on server user experiences. And so, as I said, like I was leading the economic work, and as part of the economic work, this would include reviewing the economic literature and also conducting additional economic analyses in areas that are kind of considered high priority areas. And then the findings would then be kind of transformed into what is called evidence statements, which are then used by a group of experts, which are called the guideline committee. And they use that to kind of like inform their recommendations. And we actually have written up a paper on this, so you can see exactly, really exciting. I think we had the confirmation it's accepted on Sunday. So it's going to be out in the Journal of Long-Term Care, which really describes that kind of process by exactly highlighting the economic work in particular. And next slide, please. So I'm just going to talk a bit about one guideline and one particular economic work we did for that guideline. And that's for care and support for older people with learning disabilities. And you might already kind of, well, many of you will know that, but older people with learning disabilities grow old with differently, and they grow old with complex and social care and housing needs. So their aging process can be quite different because of the learning disabilities, and they're aging also earlier. And as I said, like more likely to have these kind of multiple conditions and experience also substantial discrimination and disadvantages. So the kind of inequalities in access to health services is a really big, not just health services, but like health services and other services is a really big issue. And so out of this, well, I mean, like there's a main strategy called annual health checks in countries like the UK, which really seek to address some of those health inequalities by ensuring access to early identification of those problems. And what that actually means is that GPs have a responsibility and also get kind of money for inviting people with learning disabilities every year for their health check. And that actually covers nowadays quite a wide range of different conditions. And so that's why we derive from that kind of border review questions of access to different types of services, we derive that question of, are annual health checks cost effective for this population? And then the design is the one that Martin referred to before. So that kind of decision analytic modeling. And we actually use what is called Markov modeling, which kind of means that, and I can show you in a moment, that people are moving repeatedly through the states. And the analysis is cost utility analysis. So the outcome, so the cost measures we used were those to the NHS and personal social services, and the outcome measures were health-related quality of life measured in QALYs. The next slide, please. So yeah, here you can kind of see the model structure that we used in really simplified form. So basically, it's kind of hypothetical cohort that is offered annual health check, or another cohort which is not offered annual health checks on a regular basis. So the cohort of people enter each year with a certain probability, those kind of different health states. So, and then they could either develop a health condition or not develop a health condition. And if they develop a condition, they could either be identified or not identified. And if they're identified, they could either get treatment, and in some cases, actually, kind of, they already received treatment, but they would get better treatment because of the annual health check, or they could not get that kind of treatment. And each state has a kind of specific cost and quality of life rate attached to them. And then altogether, at the end of the cycle of 1 year, people could either be alive with a health condition, or they can be alive without the health condition, or they could have died, so be dead at that point, either because they died from the health condition or because they died of other causes. And we covered various conditions that you can see: diabetes, hypertension, breast cancer, bowel cancer, osteoporosis, and hearing and vision impairment. But that's not all the conditions that are covered by annual health checks, but these are really the ones that we could cover based on on the evidence we had mainly, really. And you can also find that kind of work published in BMC Public Health if you look for it. I'm also happy to forward it. So next slide, please. So the findings really show, so I presented the cost at that time because I think it was just important to kind of have the cost without the cost of the intervention, so without the cost of the annual health checks and with the cost of the annual health checks. So you can see the mean costs are actually quite low. So the additional cost between, like people getting annual health checks and not getting annual health checks in terms of, treatment costs and things like this, it's not actually that much. It's £120. So that's just the additional cost, and that's quite low because the probabilities of actually developing those conditions, even though it's relatively high among that population, but it's still overall relatively low. And then getting treatment that expensive is also not that high. But then you can actually see the kind of additional cost if we consider the intervention cost is almost £5,000. And that's because we actually spend quite a lot of time with that guideline committee group who are experts in the field to evaluate those costs. And we really included components that are not always included typically in the kind of annual health check costs. So that included the support worker and also really the time that it takes to support that person to attend those annual health checks. And then you can see that the additional quality adjusted life years, they were just 0.08 per person on average. And then you have the ISA that Martin mentioned. So that's the additional cost per additional quality gained. And without the cost of the annual health check, it's actually very, very low. And that's good in terms of the cost effectiveness. That's a low cost effectiveness threshold or value. And then it's actually really high if you then include the cost of annual health check. So it's almost like 90,000. And yeah, so I think, yeah, going to the next slide. So basically, according to NICE criteria, that's not cost effective. So they have a threshold, as Martin presented, between 20 and 30,000. So this is far above the threshold. And that actually put us in quite, dilemmas, or not us, but at least NICE and the guideline committee in quite a dilemma situation, because obviously you don't want to say that, we shouldn't have annual health checks. So it's that kind of situation where the economic argument is maybe not the most important one, and there are also a lot of ethical arguments to consider. And it's also just important to see that the work was really explorative, because there were so many knowledge gaps and methodological challenges, which is not uncommon in that field. So I think that's really worth highlighting. And yeah, this investment would lead to even greater inequality and equity, with again economic implications of which we probably don't know many. And so therefore, I think NICE was quite, or the guideline committee was quite wise in kind of like thinking a lot about how to kind of turn that around into good recommendations. And they actually came to the kind of decision that it should be recommended. There is just a lot more system support needed, so that actually people can, not just really get those annual health checks, but also really get the kind of good treatment that they need. And that there might be other ways of looking at early identification and treatment for that population, and that we also need more research to look into this. I think that's
okay.
it from me.
Okay, thank you. Thank you, Annette. I'm going to hand over now to Michela.
Thank you, Martin. Example C, the next slide. Report on the economic evaluation included in a larger program of work, was funded by NIHR, was looking at the realist evaluation of hospital discharge services for homeless adults in England. So the overall program was led by King's College London, the economic evaluation led by LSE CPEC. We looked at the effectiveness and the cost effectiveness of different models of homeless hospital discharge care in England. The design was an observational study. We had 1 year follow-up, and we compared different specialty hospital discharge services versus standard care. And I will define everything in a minute. We looked at 17 sites. They offer different type of services, but we had also in-depth analysis in 3 of them. So for all the 17 sites, we considered the cost for NHS, social care, related to service provision, but for the in-depth case studies, we'll also drug and alcohol treatment costs, housing, criminal justice, and much more. So the outcomes for us were effectiveness in terms of bad days avoided, but also health utilities, quality adjusted life years. Thank you. Next slide, please. The care model were very much heterogeneous, and was quite challenging to find definitions. And we see in the next slide, yeah, the 17 sites were grouped in different ways. So we looked at one comparison, looking at clinical-led services. There were teams based in hospital, providing patient reach and discharge coordination, and they were compared with those that were housing-led. So for providing housing support, so housing support worker going to hospital to provide again patient reach and discharge coordination. Then we consider second comparison, looking at those sites providing access to step-down intermediate care, and they were compared with those without. So every site with typology of comparison, we had also the control. So for us, the control standard care was very basic services. So we consider one visit by homeless health nurse before discharge. So during the visit, usually the users receive very basic information on local services, nothing more. So there was no direct link to intermediate care, and there was no follow-up at all. In the in-depth case studies, we had 3 different configurations. So For the first one, we offer patient enrich based in acute care settings with the specially discharge coordination, but there was no direct access to step-down intermediate care. Configuration 2, we looked at, again, acute care settings, but there was access to step down. And in particular, in this side, there was the availability of 14 beds, residential facility, providing support to users up to 12 weeks after discharge. So the hospital-based team was very much connected to intermediate care and secured the continuity of multidisciplinary support. For the third configuration, we had a housing-led scheme with a small team of housing support workers that basically were visiting the hospital to provide care. Next slide, please. If we look at the aggregate data from all the 17 intervention sites, we can definitely say that especially homelessness hospital discharge care is more effective and also is more cost effective than standard care. Looking again at the clinical led side, the next one, they improve access to elective, plan follow-up, but this comes at a cost. The next, housing-led schemes are very much effective as clinical-led, and they are even cheaper. If we look at side offering step-down intermediate care, they are more cost-effective than those without. And in our in-depth analysis, looking at the impact for the NHS and also beyond, we can see that, the next, please, the clinical-led with step-down intermediate care and also the housing-led configurations, both of them, are more cost-effective and also cost-saving compared with the clinical-led without any step-down intermediate care. So what happened is that the cost-saving from the perspective of other public services beyond NHS is almost double compared with the saving for the NHS. The next slide, please. So the result from this evaluation support very much the implementation and the scaling up of clinical services, so they can secure positive outcomes. And the benefits are even greater if we consider access to step-down intermediate care. So in terms of housing-led schemes, they are also successful and they are cheaper than clinical-led, and they present similar outcomes. Just for our finding, really, in a nutshell, the report will be available very soon, published by NIHR Library, but also peer-reviewed publication are in the pipeline. And the results will feature also in future NHS NICE guideline to be released in 2022, looking at integrated health and social care for people with homelessness. Also, on the basis of our finding, the Department of Health and Social Care is now leading the reorganization of services in England with the creation of a new 15 million out-of-hospital care program for homeless people that is currently underway. Thank you.
Thank you very much, Michela. So I'm now going to hand over to Helen Weatherly.
Hi there. So I think I'm probably going to tell you about the cutest intervention. That is, if you like dogs. This is a hearing dogs intervention. It was based on a trial that I worked on with 3 units at the University of York, and the project was funded by the NIHR SSCR. So the idea of the intervention, hearing dogs, is to be basically a sound support and companion to people with severe and profound hearing loss. And we were very pleased to be able to do a trial with Hearing Dogs for Deaf People, which is the provider of a charitable provider of hearing dogs within England. So the design of the trial was to compare hearing dogs with no hearing dog usage by using a waiting list control. And we managed to recruit about 165 people to the study, about sort of half, 82 to 83 in each group. And we collected data at baseline and then at 6 months follow-up. In terms of costs, we calculated the cost of a hearing dog. We took a health and social care perspective, so we looked at the social care services and their costs used alongside the hearing dog, as well as healthcare services. We compared that to the social care and healthcare service usage by the waiting list group. There are a whole host of outcomes that we looked at, and I'll tell you a bit more about those in a minute. But the main ones that we used for the economic evaluation were social care QALYs. Martin talked a bit about that earlier, and also healthcare QALYs. So if you could go to the next slide, thank you. Yeah, so as you can imagine, as a sound support and a companion to people with profound or severe hearing loss, the idea is that dogs might support them on the many issues faced potentially by people, especially people who lose their hearing in time rather than congenitally. So particular issues as evidenced through anecdotal evidence, but also some published literature evidence as to mental health difficulties, anxieties, feeling of social isolation, potentially increasing need for support from other people, potentially impact in terms of underemployment or unemployment, increased risk of accidents and emotional distress. So, you know, there are lots of potential uses that hearing dogs can have in terms of supporting the person with hearing loss. And I'll go on to the next slide, please. So to tell you about the findings from the study, so we actually found that when we compared hearing dog users to non-hearing dog users, in terms of their social care QALYs, there were gains at 6 months as compared to those who did not have a dog, and also healthcare care QALY gains as well. So although those results were not significant, basically there were improved outcomes through using hearing dogs. In terms of costs, we found that we took 2 approaches. If the cost of the hearing dog was borne by the charity, and that is the case at present, where hearing dogs provide these dogs free of charge to users, then the health and social care costs in total were lower for the hearing dog arm users as compared to those who didn't have a hearing dog. But this finding was not statistically significant. However, when we took the second approach, which is to say, what if the public sector took on the costs of hearing dogs? And then we found that the costs in the hearing dog arm were a lot higher. So as Martin said, we need to bring the costs and outcomes together in economic evaluation to better inform the decision maker. So from a perspective where the costs of the hearing dogs were borne by the public sector, that is that it was paid for out of the public purse for the hearing dogs were not good value for money. However, if the public sector did not fund the hearing dog, as is the case currently, and we also looked at an alternative scenario where there was partial funding, we found that hearing dogs could potentially dominate non-use of hearing dogs. That is that they had better outcomes, as we said, higher social care QALYs and healthcare QALY gains, but also at a lower cost in terms of lower health and social care usage. So for the final slide, thank you. So just to bring together some recommendations, so we found that overall hearing dogs appear to benefit recipients in a whole range of life domains. You'll remember the slide I went through earlier on all kinds of dimensions. Obviously we focused on QALYs for the economic evaluation. I should say that obviously we only looked at this, the impact over the first 6 months from introduction of the dog to the 6-month time horizon. So within the current funding model, that is where the costs are borne by the charity, hearing dogs are typically cost effective from the public sector perspective. We should say that whilst it would not be cost effective to fully fund the provision of hearing dogs by the public sector, it might be possible that a partial contribution could be made and it would still be cost effective. So we found out these analyses by using an approach called net health benefits. Anyway, we've got a couple of publications. One is just sort of hopefully will be fully published soon. But yeah, I've sort of glossed over any kind of challenges that we faced in doing this, but overall I think it was a very successful trial. But I know that Martin's now turning to some of the challenges more generally of economic evaluation and social care. Thanks.
Okay, thanks very much, Annette and Michela and Helen. So I'm going to just bring us to a close now. Not very much more to show you. Then we'll have some Q&A. So if I'm not watching the chat, but if you have got questions or you want to just raise your hand, you'll soon be time to do that. So on the challenges, there are all sorts of pragmatic challenges of doing these studies, and we haven't glossed over them, but we haven't had time to do them. We don't want to underestimate the challenges of doing these things, but also don't want to make them sound too horrible that nobody ever tries them. But the challenges would be the sorts of things you've been hearing from people about getting data, about measuring outcomes, working, with people with a whole range of other conditions, circumstances in their lives, which makes data collection sometimes quite tricky. So on here, I put some more general challenges. I'm not going to go through and read these out or explain them in detail. That these are challenges of moving from economic evidence to having an impact on policy or practice. I wrote about those in a paper with Gloria Wong, which is published in World Psychiatry, which is an open access journal, last year, in the mental health context. So you can please go there or get in contact with me. I think the first 6 are included in that paper, and I've been working on this subsequently. But the point sometimes is that in some areas we don't have economic evidence that is sufficient. We don't have the evidence that's there, or there are gaps in the evidence. Sometimes we have information that something is worth it. It's worth doing it either because it dominates, like the hearing dogs that Helen just talked about. They're more effective and they might save money, but they might still be seen to be unaffordable. Somebody's got to put the money in to achieve those outcomes and perhaps those down the track savings. Thirdly, there might not always be real savings. It might be that the savings that occur are the costs of unpaid care that are being reduced, which is wonderful in reducing the burden and the stresses that some carers might experience, but it might not lead to real savings in public budgets. I won't go through the rest of those, but I think sometimes there are challenges in the translation of the evidence into practice and into policy change. We need to remember that as we go forward. So 2 more slides to finish. Plus the acknowledgement one. So the first thing to say, I mentioned earlier the Essence project. And so Helen and Michela and Annette and myself and some other colleagues are working on this project. And the purpose of this, you can see in the right-hand box there. There was a study already conducted, which we finished a little while ago through SSCR, and this is the kind of Essence 2, this is the follow-on. And what we're trying to do in the study is to gather economic evidence from adult social care. We're pulling it together in one place, and you go to the website there, you will find a fair bit of that gathering. There's some more updating to be done, but we've got a lot of material there. What we're trying to do is then, some cases, to produce summary accounts of what the economic evaluation evidence is telling us. Sometimes those economic evaluation papers are a bit technical in places, quite difficult to understand sometimes. So we're trying to produce these more lay language, less technical versions of the findings. So we're trying to do that. We've got about, I think, 18 or 19 of those summaries on the website today. We do various training and other activities, and we're looking for new areas of adult social care where economic evidence might be generated, and we might be able to do, even if there was an effectiveness study but no cost effectiveness, it might be we could do some simulation modeling, mathematical modeling of the kind that Annette talked about could be done to get some economic evaluation evidence. So very, very final slide. With another picture I took just very close to my house. So two quite challenging questions to you. First, why would a decision maker not want to know the economic consequences of a potential or actual decision? I cannot imagine why they would say, no, we don't want to know. We don't want to know. I'm not saying they need to take them into account, but it would be bizarre for a decision maker not to want to know what the costs are of the actions that they are proposing or planning. And so my challenge to the research community will be, why would you not do an economic evaluation? If you're doing a study of effectiveness, why would you not also look at cost effectiveness? Again, the decision maker can ignore that information, but it just seems strange to me that people would not want to have that component. And I'm definitely not trying to get more work for myself, because I've got more than enough work to keep me going for the next 15 years. But I think, economic evaluation, I think, does need to be a key part of any evaluation in the social care field. As I hope we've explained, it's easy to understand. It's usually straightforward to undertake, although complications can arise. And I've got colleagues that may be on the webinar, but certainly have got experience in this area, where you can hit some problems with study design, or the data don't come in quite the way you expected. Other things happen. And yes, it gets complicated, but the underlying principle is very easy to understand and very straightforward. And it's not antagonistic to what happens in the rest of an evaluation. It's consistent with that sort of approach. So our final comment will please give it a try, or please contact us if you want us to give it a try. And then finally, a disclaimer, I realise I haven't got the proper SSCR words up there, but what we presented are our words alone, and not necessarily the words or the views of any of our funding bodies or our employers. So I'm going to stop sharing. Hopefully Angie will help me to, thank you. If you have some comments or questions you'd like to raise, please just stick up your, be easier to be a virtual hand, I think, because I can't see everybody on the screen at once. So virtual hand, or type something into the chat to say you want to ask a question. So over to you. I can ask a question to anybody on the call. If you've been involved, if you're not an economist, not an economic evaluator, but you've been involved in a study with economic evaluation, you don't have to say whether it's a good or bad experience, but what were the things that you found most challenging? Any thoughts? Adelina, I think has got a question. Yeah, Adelina, sorry, over to you. Yeah.
Yeah, I think a very interesting question for me is always, which is, especially with regards unpaid care, is which is the perspective we're adopting, and which is the exact question. And I think in the case of interventions, it's a bit easier, but quite often when we try to value cost unpaid care, we might be answering from the point of view of the person who provides care, or from the point of view of the person who receives it, and we might get completely different answers depending on the methods. And I have a feeling that there's still a lot of work to harmonize the methods and to harmonize the approaches, particularly in this area. This is more of a comment than a question, but it is a reflection on puzzling as to how to compare different studies that try to cost unpaid care.
Let me just I'll do a quick answer myself, and then if others want to come in. I mean, I know, we all know, I think when you ask people who have social care needs about how much unpaid care support they get, you get one answer. If you ask carers how much support they give, you get a different answer. Those things don't usually match up. I think the latter, the carer's view, is usually more hours than the person receiving the support's view. So I think there's already a kind of disjunction there. And then the nature of the support and so on would then probably lead to a different cost you'd want to attach. So I think there's a nice methodological question there for somebody to examine, Adelina, maybe. But I think you're right. I think this is difficult, and I think why it's difficult and important, because there are studies that have clearly shown that if you, well, and some of the examples we've seen today, if you don't include the unpaid care costs, you get one kind of conclusion. If you do include it, you get a different conclusion. And so it's very, very important that we value on the unpaid care, which is appropriate. Annette or Helen or Michela, do you want to come in with anything on that? You don't have to, but if you have anything to add. Nope. Okay, I'm going to go to, so Kritika, you had a question. Do you want to, I'll hand over to you to read your question out. So.
I just wanted to ask about social return on investment, because it doesn't come up a lot in social care research. And I just wondered what the panel's opinion was about whether there should be a bigger role of it. And Vanessa's asked a really similar question about it. So I can just hand it over to her, so then you can just answer it both.
So Vanessa, do you want to ask your question, say your point, and then I'm going to see if colleagues want to answer on that. So Vanessa.
I hope you can hear me. Sorry, I had a problem with with the sound that entered twice.
All the way from Barcelona, we can hear you. That's fine. Yeah.
Okay. Yeah, I basically wanted to ask about, because you didn't really talk about it, and to talk about the weight given, because it's kind of become very trendy, the social return of investment methods, and how you feel about the appropriate place for each of them. Is there a point in which you sort of feel that it's necessary to go for the full-blown economic evaluation, you know, in terms of policymakers' decisions, and also specifically thinking about how to get around the challenges of doing economic evaluation in innovations of services where you've got things happening at quite a small scale.
Okay. So Helen, I don't want to put you on the spot, but I wonder if you have anything to add on this.
Yeah, I mean, in terms of social return on investment, I hold my hand up to feeling a little bit conflicted on this, really, because I mean, as a care economist, my bread and butter is in economic evaluation. But I recently participated, perhaps a couple of years ago, with York Health Economics Consortium on a Public Health England funded return on investment project for social care interventions. And I think there were great ambitions and ideas behind doing the project, which I really kind of believed in, which is, you know, we've got a whole load of economic evaluations in social care have been undertaken, and they've used different methods. How can we put them alongside each other, and how can we understand the benefits and costs for the providers, because there is a real demand, an increasing demand in social care provision, you know, for this kind of information. And certainly whenever I do an economic evaluation, quite often the providers will say to me, oh, can you do a return on investment as well? So I think, you know, the demand's there, and certainly I've had interest in the area. I suppose on the side where I feel a lot more cautious, there's 3 or 4 things to say, really, is that, you know, firstly, virtually every single return on investment study I've seen, and I think Richard Cookson and others at PHE did a public health return on investment study, which was published a few years ago now. And pretty much every single public health intervention was, you know, had a positive return on investment, and therefore might be considered a good thing to do. So it was potentially quite an attractive thing, you know, particularly for a provider trying to produce a business case. But at the same time, you know, that method, it sort of hides the heterogeneity within the methods that are used for economic evaluation in social care. It sort of skates over those, I feel. Also, it often talks about, you know, you can realize these savings or returns, but actually it's not clear if those savings are realizable and over what time frame they might be accomplished. And I suppose finally, I think the point I want to say was they don't really kind of obviously incorporate opportunity cost, or some idea that Martin was talking about in terms of, you know, is it worth it kind of idea. So I suppose my overarching view is I feel very cautious about return on investment, but I realise that in practice there's quite a demand for them.
If I just want to add to that, I think Helen's given a brilliant answer actually, and I'm just recapitulate it. My view, particularly as this is being recorded, I'll be careful what I say, but I think SROI, social return on investment, is kind of good, bad, and ugly. The good bit is what it tries to do is very, very assiduously, very carefully identify all the potential benefits of an intervention or of a policy or practice, and then try and work out what the impact is for each of those different areas, and perhaps put a monetary value on it. And that's really good. And I think the process of engaging people who use services and so on in that identification of benefits and outcomes, I think that is really good. Okay, so that's good. That's the good bit. The sort of bad bit is, I think, is what Helen said about it, oversimplistic. And I think that I have concerns about the kind of design that SROI studies have done. I think they are very simplistic. And I think therefore they miss some of the nuances that, and therefore raise doubts in my mind about the conclusions that are drawn. The ugly bit is, if I'm really quite nasty, is it's a marketing ploy. I mean, SROI is cost-benefit analysis, but not done very well. People that trying to sell SROI, it's a marketing ploy sometimes. So I really do worry sometimes. There are some very good things to it, as I said before, but I also worry that there's some rather, shortcut evaluations which are perhaps not going to be as robust as we would need for key decisions. So I think the UK government has rode back from its enthusiasm in this area. There was a lot of enthusiasm 10 years ago. You don't see SRI mentioned very much now in the UK government. So,
okay, thank you.
So there's a point from Diane Fox. Diane, do you want to read your point out? Wherever you are. No, I can't. Okay, so Diane's, she has no microphone video. Okay, so let me read out Diane's points. That's fine. So given that there will be no savings to public budgets to relieve the burden of informal carers, do you think service commissioners, providers will be inclined to research this area? So good point. So does one of my colleagues want to say anything on this? So this is about not giving adequate research attention to unpaid care because there's no real savings if we do something to relieve the burden on them. Any thoughts? Or anybody else? It doesn't have to be just a two-way dialogue, whatever. You want to come in? I mean, my quick response would be that I think in the social care area, I don't think we have a problem with the research funding business, if you like. I think that research funders get it in terms of the importance of unpaid care. If I think about NIHR or the research councils or the research charities, I think, in fact, the research charities led the way quite often in this area, Alzheimer's Society, for example. So I think they get it. The challenge then is whether the commissioners then take it on board. And as Annette explained before, when NICE are doing their appraisals, they don't look at unpaid care costs. They do look at health and social care budget costs only. And there is a danger, therefore, that they would miss things that are important to carers. But to their credit, what NICE would do would be to make a clear statement. If they think the costs of unpaid care are really important in a particular area, they will kind of note that in the way in which they would summarize their findings. So they don't necessarily put it into their incremental cost effectiveness ratio calculation, but they do emphasize the importance of it more generally. Okay, Adelina, did you want to come in on that point or a different point? Happy to go to you anyway. So,
yeah, sorry, I think it's a great topic and question, and there are costs of unpaid care that fall back into public budgets, especially when working age carers stop providing care or when unpaid carers need health care as a result of burnout, for example. So, and I think quite often in economic evaluations, we've only been measuring the short-term costs of unpaid care, but we don't look at, for example, the public pensions costs implications of unpaid carers reducing their work or withdrawing from work to provide care. And I think we're not quite there yet in having a simple method in that you can just say, well, you know, if an unpaid carer at age 65 stops working and does this extra amount of care instead, this is the cost to the public purse in 20, 30 years in terms of benefits, pension, you know, having made less pensions contributions and so on. And I do think that this is something that hopefully we will be able to address as more and more research now on the relationship between employment and unpaid care, and hopefully into the public purse costs of that as well.
Thank you. And there's a paper that I contributed to, but Nick Brimblecombe led, which is from a previous SSCR funded study, which is looking at young adult carers and showed the consequences for them in terms of costs over a relatively short space, not the long term that Adeline was talking about, but those young adult carers had high costs in both a monetary sense and in a psychological sense in terms of disrupted education, employment chances, earnings, and so on. So, you know, even over a very short space of time, you can see some of the direct costs falling to those carers. So you'd want you know, decision makers to picking those up. Okay, we've got one more question. Go to this last question. It's from Vanessa. So why don't you ask your question? Okay, Vanessa, Vanessa Davey?
Sorry.
Yep. Yeah.
It was asking whether there are any studies that that take this perspective of the sustainability of unpaid care when looking at different care support scenarios for formal support, thinking about kind of particularly the balance between providing institutional care and home-based care.
I'm going to open. I got one quick answer, but does anybody else want to come in? Doesn't have to be anybody in the webinar want to say about these other. I mean, certainly one thing I mean, there's lots of studies which try to understand how, for example, providing more formal support changes the need for informal support, unpaid care, and whether unpaid care and paid care are complements or substitutes. And I think it's quite a complicated relationship, as we might imagine there. But I can also think of, I mean, the START evaluation, which I didn't have time to cover in the presentation, but you can see on the slides later. But that's a study of dementia, family carers of people with dementia, and has a 6-year follow-up. And over 6 years, it's still found that a very simple intervention, which is pretty low cost to develop, is still generating benefits in terms of better mental health for carers, better qualities, better quality of life in a more generic sense. So I think, you know, I think supporting carers do an amazing task, and actually sometimes they don't need very much to help them to continue to do an amazing task, but they do need something. Some people do need a lot of support, but some people don't need very much, but they just don't get it. So I think we need to give more attention to carers within the system, and research can hopefully help with that. Okay, I'm going to stop at that point just so you can go away and get your mid-afternoon cup of tea. So I'm just going to thank Helen, Michela, Annette, and thank myself, I guess. But thank you very much to the rest of you for being here. We'll put the recording onto the